So, welcome, greetings, and welcome to another live stream on the Oral Pathology 360 channel. I'm Dr. Mandana Donahue, your host for the day, and it's absolutely lovely to have you here with us for another episode. And yes, in the last month, we started with the certification-enabled content. The response has been amazing, and you will be happy to know that today's session also is certificate-enabled, which means that all you need to do is just watch the live stream, put in a comment in the live chat, follow the link in the description or the pinned comment to the payment gateway, pay the processing charges, complete the assessment questions, and receive your certificate within 24 hours if you score above 80%. And if you don't the first time, not to worry, just try again. If you have any other issues, you can just get back to me. And coming to today's topic, we have a Beyond Borders session, which I have cheated and again fitted on Tuesday, but that's because Iran time zone is the same as us almost. And we have soft tissue tumors of head and neck, a diagnostic approach by Dr. Pouyan Aminishakib, a very good friend and a good oral pathologist from Tehran University. Someone who most of you will recognize. We have attended a number of very fantastic sessions that he has organized in the last 1 year, and we have all seen him. So he is not a new face. Thank you, Dr. Pouyan, for joining us today. It's a great pleasure to have you here.
Thank you very much for having me.
Most welcome. On our panel today, absolute delight to introduce and welcome a dear friend, Dr. Simarpreet Sandhu. It's really lovely to have you here. She is professor and head of Department of Oral and Maxillofacial Pathology at Genesis Institute of Dental Sciences and Research, Firozpur, Punjab. She will be moderating the session. She's an experienced researcher with more than 80 journals, publications, and 6 textbook contributions. She has been vice president of the Indian Association of Maxillofacial Pathologists and organizing chairperson of the 27th National IOMP Conference and is presently the Secretary General of the Asian Society of Oral and Maxillofacial Pathologists. She's a nominated member of National Academy of Medical Sciences and received the IOMP prestigious Dr. R.M. Mathur Award in 2012 and a Women of Purpose by Flo in 2019. She has been on the channel before, made some wonderful presentations, both on the fibroosseous lesions and as a part of the O presentation on osteoradionecrosis, which you can always watch. And also delighted to welcome and introduce Dr. Ranganathan, Professor and Head of the Department of Oral and Maxillofacial Pathology, Raga Dental College, Chennai, as the expert today. Sir is a fellow of the American Academy of Oral and Maxillofacial Pathology and the Indian Association of Oral and Maxillofacial Pathologists. And I can very definitely say that irrespective of which part of the world you are from, when you hear his name as an oral pathologist, I'm sure you think, oh, I know him. And that's because you do know him. He has made over 130 presentations and invited lectures, has over 170 publications, including contributions to various textbooks. He has considerable professional contribution too. He is currently the president of the Asian Society of Oral and Maxillofacial Pathology, secretary to the International Association of Oral and Maxillofacial Pathologists, and chairperson, Fellowship Committee, Indian Association of Oral and Maxillofacial Pathology. He's also been the president and honorary secretary of the Indian Association and an Asian counselor to the International Association. What I have to say is, to sum it all up, he is very busy, and yet what is truly endearing and admirable about him is that he always has time for more oral pathology. This is his second time on the channel. He contributed to a live stream on career-oriented look at the graduate Indian oral pathology training, and much beyond that, behind the scenes, he has been available to me and kind enough to give his counsel throughout this year as this channel has been growing, and I have come to really depend on his wise counsel that he is very generous with. Thank you, sir, and thank you for being with us today. Now, with a warm welcome to all of you again, I request Dr. Simarpreet please to take over and introduce our speaker.
Thanks, Mandana. Good morning, Dr. Ranganathan, and welcome, Pouyan, to the Indian space. And we are looking forward to meeting you, in person also. And congratulations, Mandana. It happens to be the 61st webinar, and it's great that you put together a webinar on a very challenging topic, which is soft tissue tumors of the head and neck. And to unravel the diagnostic enigma, the enigmatic pathosis, we have Dr. Pouyan Aminishakib, who's an associate professor in the Department of Oral and Maxillofacial Pathology and Vice Dean of Global Strategies and International Affairs, School of Dentistry, Tehran University of Medical Sciences, Iran. Besides being an active academician and researcher with numerous publications and presentations, he's an active academician, he contributes to editorial board of numerous journals, is a member of many professional bodies, and is instrumental in conducting numerous international education events for the School of Dentistry at Tumors, which Mandana has said, and we've attended, and thank you for doing that. They were a treat, Dr. Pouyan. And today, yes, we have been enjoying it for the last 2 years in the COVID. So today I pass it on now to Dr. Pouyan to take us through the enigmatic oral soft tissue tumors of head and neck. Over to Dr. Pouyan.
Thank you very much. Good morning, everyone. It's a great honor for me to be here with you. I would like to thank, first of all, I would like to thank Mandana for her kind invitation, and I would like to express my sincere appreciation to both Professor Ranganathan and also Professor Simarpreet to be with me here in this presentation. Okay. As Mandana will explain that soft tissue tumors and head and neck region is a challenging topic, and I will try to give you a short introduction that how you can approach this lesion in head and neck region. First of all, let me give you a short introduction. I am a member of faculties of School of Dentistry, Oral and Maxillofacial Pathology at Tehran University of Medical Sciences. We have 5 members, 5 faculty members in our schools, and you can see here in the left side at the corner are retired professors. Also, I am a member of Cancer Institute Hospital, adjunct associate professor. Cancer Institute Hospital at Tehran University of Medical Sciences is a referral center for cancer cases. And unfortunately, we have more than 100 cancer cases in our center. Several of these cases are directly associated with head and neck region. And also, it is a great pleasure for me to be a member of a private lab in Tehran, Danish Path Lab, and I work at this private lab. And again, unfortunately, we have several cases of head and neck cancer. Okay, let me give you an outline of my presentation. At the first step, we will discuss about benign or malignant lesion, how we can make a decision about a benign or malignant lesion. And we will talk about a practical diagnostic approach to soft tissue tumors. We will have a look at FNCLCC grading system. And after that, we will negotiate about AJCC TNM staging for soft tissue sarcomas, and we will compare 7th and 8th edition of AJCC TNM staging. After that, we will evaluate protocol for examination of resection specimen for the patients of soft tissue sarcomas, and after that, we will have a short conclusion. Okay, at the first step, it is a very important issue to make a decision about if the lesion, a soft tissue tumor, is malignant or benign. You have microscopic appearance of the lesion, including shape of cells, pattern of cells, and stroma of the tumor. And also you can evaluate behavior of the lesion using clinical findings and radiographic features. When both of these findings at the same site, it means that you have microscopic appearance of the malignant lesion and behavior of a malignant lesion with destructive and aggressive behavior, you don't have any problem. But the problem arises when you have a microscopic appearance of a malignant lesion with a benign behavior, or you have a destructive behavior with microscopic appearance of a benign lesion. Let me give you some examples. When you face metastasizing amyloblastoma or metastasizing pleomorphic adenoma, you have entities with behavior of malignancy, but no microscopic changes and alteration, including cellular atypia or significant mitotic figures are seen in these lesions, but you have a malignant lesion. Or at the other side, when you are coping with some lesions, including ancient schwannoma or pleomorphic lipoma, you have lesions with microscopic malignant features, but without any destructive and aggressive behavior. In such lesions, you can see you can see the, cellular atypia and also sometimes giant cell lesions, but no destructive behavior is seen. Therefore, at the first take-home message, I recommend that let's trust on the behavior of the lesion more than the microscopic features. And at the second part, we have some soft tissue tumors of intermediate biological behavior. Some of them are locally aggressive and some of them rarely metastasizing. Sometimes it is not possible to draw a line between tumors of intermediate biological behavior and sarcomas. And you should correlate both clinical and radiographic findings with microscopic features. You can see here, it is always mandatory to have clinical features of the cases, especially soft tissue lesions, and also imaging radiographic features, which are commonly well representative of the clinical behavior of the lesion, and correlate these features with microscopic findings. Therefore, as a second take-home message, it is highly recommended to be in touch with your treating colleagues, especially radiologists and surgeons. It is necessary to be in touch with them, share your documents, share your knowledge with them, and ask them about what they need for arranging and planning treatment of the patients. And also, it is critical to convey the clinical significance of your diagnosis. You should be well aware about your consequences of your diagnosis. Okay, let's start the first step, how we can approach a soft tissue tumor. At the first step, it is very critical to evaluate the shape of the cells, pattern of the cells, stroma of the tumor in soft tissue tumors. If you would like to have a great assessment of shape of the cells, you can categorize the shape of the cells in these four groups: a spindle cell tumor, a small round cell tumor, epithelioid tumor, and pleomorphic tumor. You can see here an example of a spindle cell tumor. A spindle cell tumor could be blunt-ended or be point-ended, and it is mandatory to identify, determine the exact shape of the cells to make a definite diagnosis. And also round cell tumor are some soft tissue tumors with round cell and round nuclei. They might be small or large. And also sometimes you have epithelioid tumor with significant eosinophilic cytoplasm and great large round centrally or excentrally located nuclei. Also, you may have pleomorphic tumor. You can see here in this photomicrograph, sometimes you have tumor or sarcomas with different tumor size and different tumor cell size and cell shapes. Okay, let's have a look at the first case. A 43-year-old female with exophytic mass on her palate for about 1 month duration and no significant past medical or past dental history. You can see here the image of her lesion on the anterior area of her palate. This image taken after incisional biopsy. And you can see here photomicrograph of the lesion here. You can see here some ill-defined cell borders with a scarce cytoplasm, uniform cytomorphology, and solid, especially solid sheets of round cells with finely granular chromatin. Also, it is highlighted mitotic figure here, and also an atypical mitotic figure with tripolar appearance. Let me give you something about an article published by Professor Thompson. When you have a small round cell tumor at sinonasal tract, please remember, this is a picture of mine when I'm sleeping. Please remember, you may have a master sleep. It means that you have a term stands for a group of lesions mostly seen in anterior area of maxillary bone. M stands for malignant melanoma, R for rhabdomyosarcoma, S for sinonasal undifferentiated carcinoma, L for lymphoma, E for esthesioneuroblastoma, and the second E stands for Ewings sarcoma, and P stands for pituitary adenoma. And in this case, IHC study was very helpful, and after immunohistochemical study diffused positivity for CD99 and scatter positivity for pancytokeratin and scatter positivity for NSE were observed. And non-immunoreactivity for this means CD3, CD20, synaptophysin, and S100 was seen. Unfortunately, the patient was neglected for several months, and you can see in these photos that the lesion growth dramatically and involve all palatal area of the patient. As you can see here, this case published and diagnosed as Ewings sarcoma of the upper jaw. But I would like to remind you that please be careful about some Ewing-like sarcoma, including cis-translocated sarcoma and B-core translocated sarcoma, which are currently recently introduced in literature. Okay, let's take a breath and let's go ahead. This is the photomicrograph of mucormycosis in one of my patients. Unfortunately, tested positive for COVID-19, and he also had a history of diabetes mellitus. Okay, the next step to make a definite diagnosis of soft tissue tumors are determining the pattern of the cells. If the pattern is fascicular and storiform or alveolar or biphasic or cystic, zodocystic or glandular or zodoglandular pattern. You can see here fascicular and storiform pattern. Spindle cell tumor, spindle cells are arranging in fascicle, interlacing fascicles, and also in this photo, you can see a small round cell tumors arranging in alveolar pattern, similar to what you can see in pulmonary tissue normally. Also, when you can have both epithelial or epithelioid cells in close connection with mesenchymal cells, you have a biphasic tumor. And also you can see here at the left side, the cystic or zodocystic appearance, and on the right side, you can see glandular, zodoglandular appearance of the tumor, which are some examples of tumoral pattern. And also it is necessary to determine the stroma of the tumor, if it is fibrotic, inflammatory, myxoid, chondroid, or osseous. You can see here a fibrotic stroma of a bland-looking spindle cell tumor with no evidence of cellular atypia. And also you can see here a high-grade carcinoma in an inflammatory stroma, an area of necrosis. Also, when you have a tumor with hypocellularity, a paucicellular tumor, you are facing with a myxoid stroma. And also you can see here on the left side, the chondroid stroma, and the right side, you can see here a osseous with osteoid formation pattern, stroma, sorry. Okay, let's go to the second case, a 32-year-old male with buccal mucosal mass for 2 months duration and unremarkable past medical and past dental history. We can try our approach to diagnostic approach to soft tissue tumor in these cases. You can see here low power photomicrograph of the case of the soft tissue lesion on buccal mucosa of the patient. You can see here several cross sections of various size blood vessels. Some of them are staghorn-like appearance, and also you can see here tumoral cells. You can see here again tumoral cells separated by an eosinophilic fibrillary stroma, and also with higher magnification. You can see here a uniform spindle, two somehow rounded cells, bland-looking cells, and vesicular chromatin. In the previous slide, you can see here fibrotic stroma at the background of the tumoral cells. In this photomicrograph, also you can see a scattered mitotic figure, typical mitotic figure in this tumor. And it seems that, again, IHC study might be very helpful to make a definite diagnosis. Therefore, Ki-67 to evaluate proliferative activity of the tumor showed that less than 5% of the tumoral cells with proliferative activity. And also Vimentin showed diffuse positivity for tumoral cells and other normal structures. And also CD31 decorated the background normal vessels, and you can see well the vessels at the stroma of the tumor. Also, the key biomarker was CD34, which showed diffuse and strong positivity in membranous area of the tumor, all tumoral cells. And finally, we make a definite diagnosis of solitary fibrous tumor, and you can see how we can approach a soft tissue tumor. At the first step, we determine the shape of the cells. At the second step, we evaluate the stroma and the pattern of the cells, and we utilize the IHC study to make a definite diagnosis. Okay, take another breath and let's go ahead. This is a photomicrograph of Aspergillus infection in another COVID-19 positive patients in our center. You can see silver staining here, and we could identify, we could detect fungal infection in this patient. Okay, this is a time to classify soft tissue lesions according to the line of differentiation. It is very important to, at the first step or at the second step, to determine the line of differentiation of soft tissue tumor. If the tumor is fibroblastic or myofibroblastic tumor, or adipocytic tumor, or a smooth muscle tumor, or originated from perivascular cells, or originated from skeletal muscle, or it is a vascular tumor, or it is a nerve sheath tumors. Also, we have tumors with uncertain differentiation. The prototypic example of these lesions are synovial sarcoma and alveolar soft part sarcoma. You may cope with in head and neck region. Also, when you are facing an extremely undifferentiated tumor, you can just classify this tumor as undifferentiated sarcoma according to the shape of the cells. For example, undifferentiated spindle cell sarcoma, pleomorphic sarcoma, round cell sarcoma, or epithelioid sarcoma. But in few cases, you may face an extremely undifferentiated sarcoma without differentiated to any kind of the tumoral cells. Okay, I explained earlier about immunohistochemistry, but I would like to emphasize that IHC study is used to confirm histologic impression, also distinguish among histologically similar tumors, and also it is used to support diagnosis of a rare tumor type or support diagnosis when a tumor arises in an unusual anatomic site. But it is very important to use immunohistochemistry, but please stick in your mind that sometimes immunohistochemistry is not a real helping item in making your definite diagnosis, and sometimes it might be an immunohistoconfusion. Therefore, I would like to recommend you to arrange a well-designed panel for each tumor according to the shape, pattern, and the stroma of the tumor. I provided here 4 tables from the Dr. Dabb's book, who recommended to use these panels for the tumor, soft tissue tumors according to the shape of the cells. For example, when you have a small round cell tumor, please use keratin, EMA, desmin, myogenin, which commonly positive in Rhabdomyosacroma, synaptovisin, S100, CD49, or leukocyte common antigen. You can use this biomarker to rule out lymphoproliferative disorders, especially lymphomas. And also you can use CD99 to identify if the lesion is a Ewings sarcoma or not. And also TLE1 is commonly used to detect Ewings sarcoma, especially poorly differentiated synovial sarcoma, in head and neck region, and all tissues of the bodies. And also you may have epithelioid, also you may have a spindle cell tumor, and you can use keratin, EMA, beta-catenin. Beta-catenin is very useful and showed nuclear positivity in fibromatosis. Desmin, SMA, H-caldesmon to confirm, when you have a myogenic tumor originating from skeletal muscles, H-caldesmon will be very helpful. Also S100, MDM2 is commonly used in liposarcoma, CDK4, MUC4 is commonly used in fibromyxoid sarcoma, CD34, and also CD31 and TLE are used in a spindle cell tumor. Also, you can use ERG to determine if the tumor is originated from a vascular tissue. Also, the next one is epithelioid cell tumors. You can use keratin, EMA, MUC4, desmin, SMA, caldesmon, and also you can use HMB45 and MART1 to rule out malignant melanoma and other biomarkers, including CD31, CD34, ERG, and SMARCB1. Okay, let's go to the next case, a 22-year-old female with swelling on left side of her face with unremarkable past medical and past dental history. You can see here her face. You can identify here a lesion with the expansion on left side of her face. Computed tomography and radiographic features will demonstrate that there is a destructive lesion from sinonasal area extending to the eye lobe of the patient and also extending to the other side, destructive and very aggressive. And you can see here that it is going to destruct even septum of the nose of hair. Photomicrographs will demonstrate that you have a small round cell tumor arranged in alveolar pattern, as I explained it earlier. You can see here with a scarce cytoplasm, you can see hyperchromatism. All the cells are arranged in alveolar pattern. They are located far from each other. And also you can see a scattered mitotic figure in these tumoral cells. And also you can see the nests are separately located and surrounded by a fibrotic stroma. Again, IHC study was very helpful in this case. Pancytokeratin showed negativity for tumoral cells. Also, you can see here internal positive control for ductal structures of minor salivary glands located in the left side of her face, and also CD45 or leukocyte common antigen showed negative expression in tumoral cells. You can see positivity in scattered inflammatory cells surrounding tumoral cells, and also chromogranin and synaptophysin additionally showed no expression in tumoral cells, but also desmin showed diffuse strong cytoplasmic positive in all tumoral cells. Also, we use myogenin and myod1, and both of them showed nuclear positivity in tumoral cells. You can see here myod1 positivity for tumoral cells. And after that, we sign it out as alveolar rhabdomyosarcoma, as you can see, evaluating and going through all the steps of making diagnosis of a soft tissue tumor will be very helpful, from identifying the shape of the cells, determining the the pattern of the cell arrangement, and also utilizing IHC study. Okay, let's go ahead. This is another photomicrograph from perineural and intraneural invasion of adenoid cystic carcinoma. Sorry. Okay, when we are going to write a path report for a soft tissue sarcoma, what should we do? How should we report a soft tissue sarcoma? At the first step, we are supposed to be familiar with the grading system of soft tissue sarcomas, and also we are supposed to be familiar with the staging system of American Joint Committee on Cancer and the reporting protocols for soft tissue sarcomas. You can see here, grade is currently best predictor of outcomes, especially metastases, for the majority of soft tissue sarcomas. And also distinction between low-grade and high-grade sarcomas may influence clinical decision-making, especially adjuvant chemoradiation therapy. A group of soft tissue sarcomas, mostly cases harbor translocations, exists with limited or no value of grading beyond histologic typing. In case of limited biopsy material, it is sometimes not possible to make a definite diagnosis. And also some pathologists suggesting Ki67 proliferation index instead of counting mitotic figures. We commonly use Ki67 to evaluate proliferation activity of the tumoral cells, but in some, I know in some labs, it is not common to use Ki67, and it is a matter of debate. It is reasonable to use radiologic imaging to estimate the extent of necrosis in small biopsies when surgeon or clinicians ask you to provide the grade of the tumor with a small incisional biopsy, you have to use a radiologic image to assess the necrosis of the lesion. Okay, the most common grading system is FNCLCC, which is based on 3 items: differentiation, mitotic activity, and necrosis. And each of these parameters receive a score: differentiation from 1 to 3, mitotic activity from 1 to 3, and necrosis from 0 to 2. Based on differentiation, tumor differentiation is scored as follows. When sarcomas closely resembling normal tissue, it has a score 1, and when sarcomas for which histologic typing is certain, but it is not similar to the original tissue, you can give the tumor score 2, and when you have embryonal sarcoma or undifferentiated sarcoma, you have a score 3. Considering mitotic counts, if you have more, you have mitosis in 10 high power fields from 0 to 9, it is a score 1, and when you have from 10 to 19 mitosis in 10 high power fields, you have a score 2. When you have more than 19 mitosis, you have a score 3. And considering necrosis, it is necessary to evaluate necrosis not only on gross examination, but also it should be validated with histologic sections. And when you have no tumor necrosis, it is a score 0. And when you have less than 50% of tumor necrosis, it is a score 1. And when you have more than 50% of tumor necrosis, you have a score 2. And as take-home message 3, a diagnosis should be made before mitotic rate is determined, because we have some lesions with high mitotic activity, but they are not a real sarcoma. For example, nodular fasciitis is a tricky lesion and with high mitotic activity, but it is a true reactive lesion. Mitotic count should be determined in 10 high power fields, and also you can use the 10 contiguous 10 high power field to assess the mitotic activity of the lesion. And also tumor necrosis must be confirmed histologically, and gross examination is not enough to report necrosis of the tumor. And also hyalinization hemorrhage should be excluded from assessment of the tumor necrosis. Then another important issue is about the time of assessment of the tumor necrosis. You're all supposed to assess tumor necrosis before adjuvant therapy, because after radio or chemotherapy, we have treatment-related necrosis, which could not be used for grading of the tumor. And it is necessary to use just a spontaneous tumor necrosis to grade a sarcoma. And also tumor differentiation is a combination of true differentiation and histologic diagnosis, because some of sarcomas are high grade by definition. For example, dedifferentiated liposarcoma, synovial sarcoma, or Ewing sarcoma are essentially high grade sarcoma, or even in absence of mitotic activity or necrosis. However, 3 graded classifications are recommended for both bone and soft tissue sarcomas to avoid confusion, in which grade 1 is considered as low grade and grades 2 and 3 are considered as high grade. Okay, at this next step, it is important to be familiar with the 8th edition of a staging system for soft tissue sarcomas. Tumors are described separately according to this staging system and according to the primary sites, mainly due to the differences in the prognosis and treatment strategy. For tumor locations are described for soft tissue sarcoma are extremities and trunk, retroperitoneum, head and neck, and also visceral sites. You can see here at the first step, you are supposed to report tumor size. And when you have a tumor less than 2 centimeters, it is reported as T1. And when you have more than 2 centimeters and less than 4 centimeters, it is reported as T2. And when you have a tumor more than 4 centimeters, it is commonly reported as T3. And also when you have a tumor with invasion to the adjacent normal tissue and even vital tissues, it is reported as T4A or B. And also you are supposed to report N and involvement of the lymph node as N0 or N1, and also you are supposed to report the distant metastasis as not applicable or M1. Also, regardless of the anatomic site, locally aggressive soft tissue neoplasm, for example, fibromatosis, which may recur locally but have either no risk of metastatic disease or an extremely low risk of metastases, are excluded from AJCC soft tissue sarcoma staging system. Also, you can see here AJCC prognostic staging group, in which head and neck region is not included. Also, some other kinds of nomogram is proposed to predict free survival rate for the patients suffering from soft tissue sarcomas, but additionally, head and neck region is not included. Okay, let's go to the fourth case, a 2-year-old girl with a post-auricular swelling and without significant past medical or past dental history. You can see here the lesion is located at the post-auricular area. The bulging of the lesion is, you can see the bulging of the lesion at this site. And on core needle biopsy, you can see here a fibrotic stroma, and with a higher magnification, you can see a spindle cell tumor with bland-looking appearance, no significant mitotic activity, and no cellular atypia is observed, and also no necrosis is seen in microscopic assessment of the tumor. Again, we utilize IHC study. At the first step, we use Ki67 to evaluate proliferation activity of the tumoral cells, and no proliferative activity is seen. S100 was positive for the tumoral cells, and Soxten, another IHC marker, immunohistochemical biomarker, which help us to detect cells from neural origin, was negative in tumoral cells in this patient. And also all smooth muscle actin decorated vessels at the background, at the stroma of the tumor. And also again, CD34 demonstrated a strong diffuse positivity for tumoral cells. Correlating with clinical pathologic findings, we signed out a bland-looking mitotically inactive spindle cell proliferation or neoplasm, and after correlation with clinical findings, a fibrous hamartoma of infancy is proposed. Okay, let's go ahead again. Sorry, you can see here an atypical mitotic figure in a Rhabdomyosacroma case. It is a ring-like atypical mitotic figure, and it is very bad for the patient to identify, to detect such atypical mitotic figure in his or her specimen. Okay, about a template for reporting sarcoma, I recommend you to use College of American Pathologists template. We commonly use this template in our center. At the first part, you are supposed to report tumor focality and also tumor site, and also tumor size based on the greatest dimension of the tumor in centimeter. And also you should report histologic type of the tumor, and in some kinds of tumor, percentage of hypercellularity areas should be reported, for example, in myxoid liposarcoma. And also you're supposed to report margins, surgical margins of the tumor, and also regional lymph node status, and also distant metastases. As I mentioned earlier, you're supposed to report pathologic stage classification based on AJCC, including T status, and also N status and M status. Regarding surgical margin, it is very important to surgical margin status is currently the best predictor of local recurrence for the majority of soft tissue sarcomas. With negative margin, the risk of local recurrence decreases dramatically. And also the margins should be submitted as perpendicular sections to make it possible to report the distance from tumor to surgical margin. And also it has been recommended that for all margins located less than 2 centimeters, the distance of the tumor from the margin be reported in centimeters. If one are present in the specimen and are not involved by tumor, or the tumor is located more than 2 centimeters from the margin, the marrow can be scooped out and submitted as a margin. And it is also possible in frozen section study. And the last case is about a 35-year-old man with a swelling, facial swelling on the right side of his face without remarkable past dental history, but several scattered subcutaneous nodules were reported. In low power examination, you can see here that you have two population of cells. In one population, you have hypocellular areas, and in another part of the tumor, you have hypercellular areas. You can see here a tumoral cells arranged in a fascicular or storiform pattern is very clear. And you can see here interlacing fascicular storiform pattern, and also with higher magnification, you can see here a spindle cells of tumor with a blunt end. And also it is another photomicrograph of the tumoral cells. You can see here a scattered mitotic figure, but there is no necrosis in this tumor. Also, the aggressive behavior is well identifiable, invading adjacent normal salivary gland tissues, including ducts structures. Again, applying immunohistochemical study, Ki67 showed significant proliferative activity of the tumoral cells. More than 30 or 40% of tumoral cells with high proliferative activity, and also cytokeratin staining showed scattered positivity in cytoplasm of the tumoral cells, and also S100 showed significant cytoplasmic positivity in tumoral cells, and CD34 showed two different populations of tumoral cells and separate them from each other. And also TLE1 showed scattered nuclear positivity in tumoral cells. It was a very challenging lesion. And after receiving a report from the surgeon and clinicians that the scattered subcutaneous lesion on the whole body of the patient was neurofibroma-like lesions, diagnosis of malignant peripheral nerve sheath tumor was rendered. Okay, take a breath again. This is another photomicrograph of my recent patients. You can see here clear cutoff between a normal epithelium and dysplastic epithelium. And at the last part of my presentation, I would like to let you know that we don't commonly use molecular study in our center, not only in School of Dentistry but also in Cancer Institute Hospital. But soft tissue sarcomas are divided into two major groups based on cytogenetic features, and I know it is commonly used in some centers around the world to apply molecular testing to make a definite and reliable diagnosis for soft tissue tumors. Soft tissue sarcomas, some soft tissue sarcomas show simple cytogenetic features, and some sarcomas shows complex cytogenetic features. And commonly, the different techniques, including chromosomal karyotype or fluorescent in situ hybridization or RT-PCR, commonly used to identify translocation or mutation in sarcomas. Okay, as the conclusion, I would like to invite you to correlate all clinical findings, imaging, and microscopic features to make a definite diagnosis. If you have cytogenetic studies to facilities to have cytogenetic data of the lesions in your centers, you can use these data in your center to make a definite and reliable diagnosis. At the end of my presentation, I would like to express again my sincere appreciation to you all, and also especially Dr. Mandana, Professor Ranganathan, and Professor Simarpreet. And it is a great pleasure for me to hear your questions. Thank you very much.
Simarpreet, are you there? Yes, you're there.
So that was a wonderful presentation. Thank you, Dr. Pouyan, for taking us through a spectrum of cases, and we've taken down a lot of pearls down from there. And I've seen the question and answer, on the YouTube. Presently, we don't really have any questions, but I wanted to ask a question. And do I do that?
Yes, please.
So I just wanted to know, what is your impression of the PUS? I mean, it keeps shifting from one, category to another, and we are always forever confused about the PUS. So any experience from your center? So.
Sorry for interruption. Would you turn on my?
I'm just trying to do that. Yes.
I cannot turn on my video.
No. I had to turn it off because the speed of the net had gone down. Yeah, please now start it. Yes.
Okay, great.
Yes.
So
would you let me have your question again?
Yeah, so I wanted to know, what is your center experience, or your personal experience of the undifferentiated sarcoma, pleomorphic undifferentiated sarcoma? since we are trying to categorize it, and then, from MFH to so many other names. So what is your experience, and how do you go about diagnosing this, the one that's troubled me so many times?
Yes, great question. Former malignant, MFH, and now undifferentiated pleomorphic sarcoma is a challenging and tricky entity, I think, and it is a diagnosis of exclusion. It means that at the first step, you are supposed to exclude all other similar lesion, including, for example, pleomorphic Rhabdomyosacroma, undifferentiated pleomorphic osteosarcoma, and other lesions. And I think there is no immunohistochemical biomarkers to make a difference.
It's more of a trash bag diagnosis. That's what they say.
And again, clinical findings are very, very helpful to make a definite diagnosis. If you have a very aggressive, destructive lesion with no expression, no immunohistochemical expression of well-known tumors, you can make the diagnosis of undifferentiated pleomorphic sarcoma.
And also, what about the mitotic grading systems that are using this thing on the Coinder grading, or what mitotic grading system are you using presently in your center?
We commonly use 10 fields, 10 high power fields, and add them to each other, and we report them as the mitotic count. Also, I know in other centers, and a square area, 1 millimeter square area is recommended to report mitotic activity of the tumor. But we commonly use 10 contiguous high power fields in our center to report mitotic count of a soft tissue sarcoma.
Okay.
Yes.
Over to
can I make a comment? Yeah.
Yes, please.
Yes, sir. I was inviting your comment, actually.
Yeah. Thank you, Simarpreet. Thank you, Dr. Pouyan. That was a fantastic, extensive lecture. And I think the one take-home message, you had multiple messages I have for the postgraduates is morphology is important. And let me try to put together this very extensive talk which you have given for the sake of postgraduates. I think the first point which Dr. Pouyan made is very relevant. You need to look at cellular features. You need to look at the behavior and the morphology of the tissue to arrive at the diagnosis. But these have limitations. And he rightly pointed out the classic example of metastasizing pleomorphic adenoma and metastasizing amyloblastoma, which can look bland, but can metastasize and behave in a malignant manner. On the other hand, you have lesions like ancient schwannoma, which can look very upsetting, but behave in a very benign way. Or for that example, nodular fasciitis, which can have a lot of mitosis, but can only be locally aggressive. So for all budding pathologists, you should be aware that morphology is the first step, behavior is the next step. And then he went on to emphasize how clinical behavior also should be taken into consideration. And it was a fantastic acronym of Mr. Sleep for round sinonasal tumors. And those of you who can't memorize mnemonics are fantastic. We use that all the time in pathology. And I really liked your case selection. And I think you had a point to tell in each and every case. The first case was Ewings sarcoma, which was a CD99 positive Ewings sarcoma. And it was a very classic case. And he did make a mention that be careful between immunohistochemistry and immunohistoconfusion, because sometimes if you get a negative result, it may be a problem with the tissue also. And there are a lot of issues with immunohistochemistry as to how they are fixed and things like that, especially in this part of the world. That's very important. But if you had listened carefully, you very, very quickly pointed out that there are Ewings sarcoma-like lesions. So you can depend on morphology only to a particular extent. And they may be a subset of what we've been diagnosing as Ewings, which could be the newer lesions. I think you mentioned the CIC DUX4 translocation.
And now the new ones, the three
sarcoma.
categories.
Yeah. And the BCOR, CCR, CCB, and 3 sarcomas.
On EPS.
Yeah. So you need to be very clear that what looks like Ewings in immunohistochemistry and histology may not have the classic T1122 translocation of Ewings. So sometimes, as our technology improves, we may be able to stratify them, like what we have been doing for salivary gland tumors.
Exactly.
And I think the second case was a classic CD34 positive solitary fibrous tumor, and that is a typical patternless pattern. And once again, if you have a confusion, you may have to resort to the STAT6, which is sort of definitive for solitary fibrous tumors. Not necessary, once again, only when there is a confusion. And I think case 3 was classic. It was a MyoD positive, straightforward alveolar rhabdomyosarcoma. And this point was very nice. I mean, he elegantly pointed out what the algorithm should be. First, you need to look at the shape of the cells, the pattern of the cells, the growth pattern, and then you decide the immunohistochemistry panel. And then it is cost effective for the patient, and you're less likely to trip on your diagnosis. And I think the fourth case was classic spindle cell lesion, where it was non-definitive with IHC markers. But given the fact that it happened in a child, looked bland, did not have any mitosis, probably it is bland. If it barks like a dog, it's probably a dog. So it's probably bland. And just like in a discussion of PUS, it turned out to be a fibrous hamartoma. By taking into consideration the IHC, the pattern, but most importantly, the age of the patient and the clinical behavior, which was a good take-home message from that particular case. And the last case was very interesting because I think it was very nice to put that as a last case, because you may know everything about IHC. It could be TLE1 positive, it could be other markers positive, it could be biphasic CD34, it could look like a synovial sarcoma, could have markers which are supposed to be synovial sarcoma, but can still take a step back, look at it holistically, and then it turns out to be a malignant peripheral nerve sheath tumor. So these are 5 classic examples of what you're likely to face if you're dealing with the soft tissue sarcomas. And I think he did summarize about the grading system, the staging system, and how we can follow the synoptics of the CAP, Clinical Association of the American Pathologists, for using it in your center if you're so inclined. And in the staging system, it was very interesting. I think he pointed out 3 important factors in soft tissue tumors. 1, mitosis, which one way to go is 10 consecutive fields, or if you have the facility, use a KR67. And he talked about necrosis and differentiation. I think these are the 3 pillars of soft tissue tumor diagnosis: differentiation, mitosis, and necrosis. And I think he was quick to point out that we should differentiate between treatment-induced necrosis and a spontaneous necrosis in tumor. So this was a fantastic overview of spindle cell lesions, what I think every beginner should know, and every expert should hear to sort of refresh their memory as to what is really important, take a step back and say that, oh, okay, sort of a revision for all of us. Let me stop here. And once again, thank you for this excellent presentation. And thank you, Dr. Mandana and Simarpreet, for giving me this opportunity. Thank you very much.
You're welcome.
Was an amazing sum up. Yeah. Thank you so much, sir. And now we have questions from few people. And we have from Dr. Joss Hill. He says, please outline a minimal panel of IHC antibodies to use for making a reliable working diagnosis, especially in resource-limited centers. So he needs to know this. Minimal panel of IHC antibodies.
Yes.
It was dealt and yeah.
Yes, as Professor Ranganthan well explained, that at the first step, we are supposed to determine if the shape of the cells are round, spindle, pleomorphic, or epithelioid. And after that, it is recommended to have your panel or limited panel of the tumors. Limited IHC panels for the tumors. I think the designing or planning for IHC is the last step of your diagnosis. You should gather all clinical information, radiographic features of the lesion, and provide a list of differential diagnosis. And after that, you're supposed to arrange your the panel of IHC biomarkers. And I have in my presentation 4 separate panels for round, spindle, pleomorphic, and epithelioid tumors adopted from Dr. Dapp's book, and I recommend the audience to use these panels for their routine work.
So, and a lot of compliments. We have Dr. Varun Rustogi and Dr. Jaya Joshi and Netta Fayaz. I think we have people from all over. So I just wanted a comment on the NTR in soft tissue tumors, which are an emerging entity. So any experience with those?
May I have your question again? May I have your
There are the NTRK associated soft tissue sarcomas. They are an emerging entity now, I think more towards the treatment orient. So do you have any experience at your center? Because that's what I would like to ask.
Yes, I explained in my presentation, several new entities have been introduced in literature according to cytogenetic studies. NTRK sarcoma, or B core translocated sarcoma, or cis translocated sarcoma, or some entities like these. Unfortunately, at our center, we don't have access to routine cytogenetic study of all tumors, and we commonly use immunohistochemical assessment of the tumors to make a definite diagnosis.
So there's somebody called Neda Faz, and she says, great conference. Be careful for TEL1 could be positive in biphenotypic sinonasal sarcoma, and it's diagnostic in synovial sarcoma. So that's a point which she's tried to make. And by and large, everybody is complimenting you on an amazing presentation on a topic which was extremely tough. It still scares me when I think of the soft tissue sarcomas. You've taken a lot of pearls from there. Thank you so much, Dr. Pouyan and Dr. Mandana, for arranging this, and Dr. Ranganathan for summing it up so beautifully. So go back and read more actually after this. That is what is the take-home message.
Thank you very much. It was a great honor for me to be with you, Professor Ranganathan, Professor Simarpreet, and I would like to thank you, Dr. Mandana, and also all audience, and I hope to be in touch with each other to share these experiences with each other.
Okay, we have last one that's just come in by Jaya Joshi, Dr. Jaya Joshi. So can I take will you take the question, Dr. Pouyan?
Yes, please.
Yeah. So she's asking how to distinguish a neoplastic necrosis from that is surgically induced. She's not understood. She wants more clarity on that part.
It could not be differentiate based on microscopic findings. You should be well aware about the treatment patient have received or not. But microscopically, it is not differentiable from each other. Treatment-associated necrosis from spontaneous tumor-associated necrosis. Please gather all information about neoadjuvant treatment of the patient to make a definite diagnosis of the necrosis, or make an accurate grading of the sarcoma.
So I think this was the last question, Mandana. Rest all of compliments from a lot of people were amazing, and they've loved your mnemonic. A lot of compliments on that. I think Thurs already mentioned that. So over to Mandana.
Thank you to all of you. This was excellent. The presentation was great. The moderation was great. Sir, your summary was great. So I have to just say great. I think I'll just keep it there. Yes. Now I have one thing. Since this came up, and since a lot of people from around, definitely from our region and other parts are also listening, is do do we have any center right now in India where we could possibly send these for a cytogenetics? Any of you are aware?
Yeah, there are a lot of centers, some of them corporate centers, which do it for us. And I think we have 2 centers in Tamil Nadu, which do that in Chennai. I do not know about the other parts of the country. I'm sure Tata Memorial has it up north. And I'm sure that Ames has it, probably a few other centers of excellence. But you can always ship samples and get it done in whichever part of the country you are. Of course, taking into account the restrictions because of the pandemic at this point in time. That's thrown a spin for all of us. But there are a few centers, and we do it only for academic purposes, or when we want to publish or for some specific research. And at least here, we do not routinely use molecular techniques as far as sarcomas are concerned. Yeah.
It's true. They would be also very expensive for patients.
Yes.
Yeah, like I think the whole point would be like the new 2020 WHO Blue Book has said they've involved clinicians. I think it's to make it like, this is a great platform, is to put people across, discuss their cases, come up with a consensus and involve more clinicians. That would be a great way forward, because they are rare entities, and some of the histotypes are even rarer. I think 0.1 into a lakh. So that is a problem, very rare, and the subtypes are rarer. So it's to share on a platform and have something like a sarcoma registry, start something like
correct.
With people helping.
Yeah. The other thing to keep in mind is this is not a very academic comment, but a very practical comment. I think Dr. Jose Hill asked the question, what was the minimalistic panel? The other point to it is, let's say it's an Ewings-like sarcoma and you classify it as high grade, whether it's cis-DUX4 or BCOT translocation. If you do not have a targeted therapy and you're going to treat them all the same, the centers are not going to use their resources to actually differentiate or subgroup or stratify them, like we do for staging for mitosis and necrosis. But if we have targeted therapy, then it makes sense to go that extra mile and do these translocation studies, like we were talking about the NTR4 translocations. So that's another thing in a resource constrained setting. We need to make sure that whatever finding we have is actually going to make a difference in the treatment of the patient. Now, this is from the practical point of view. Academically, yes, you need to know what types they are because our knowledge is evolving. So that's another thing to keep in mind when you talk about these. And I'm extremely glad about Dr. Pouyan's lecture because stress that point, how with morphology and sort of a standard panel, most of the markers which are used, we have access to that here also. Most of the times you could make a diagnosis and manage the patient appropriately. So I think that was a good take-home message. Yeah.
That's true. So I think there's nothing else that needs to be dealt. So should we be wrapping up? Anyone wants to make any additional comment? Okay, so then we will just wrap up. Give me a second to share. 1 second. So, Dr. Pouyan, thank you so much for this. This was a lovely presentation. Thank you.
It was a great honor for me to be here with you.
Thank you.
Welcome. Thank you very much.
You're welcome. Simar, you can add to your collection.
I know what you said.
Yes.
Thank you so much for the floral bouquet also, actually. I needed it.
That's nice.
You're welcome. So, and this one is yours. Thank you so much for your time and being here. Yes, thank you.
And thank you, Mandana, for motivating me to read again, go back and read the new blue book. Yeah.
That's a good way. That's a good part of it, isn't it?
Yes, it is. Thank you for making an effort and congratulations again on your 61st episode. So wishing you more love.
Yeah. Thank you. Thank you so much.
Thank you all. Keep safe. Take care.
Thank you so much.
Thank you.
Nice day.
Guys, bye.
Bye.
Bye, Pouyan. See you
Bye
again.
bye.
Bye.
Have a nice
Bye.
day.
Okay,
Bye.
I will just continue here. So we have, I have to share next week's event, which is another one from Beyond the Borders lecture. And sorry, not next week. I cancelled that. It's this week now. It's this Friday. And it's by Professor Tiago Pinheiro. I hope I got that, from Brazil. He's going to share his experiences of the amazing Amazonic lesions. And that is how the name Amazingonic has come, or it is Amazingonic, I guess. And this should be very interesting. Please note the date and the time. It's on Friday, the 20th August at 18:30 hours in India. That is 6:30 in the evening. If you go, if the event is already put on the live stream, expected live stream. So if you're on the channel, just check it out and you can put a reminder, and you will also see what the time is on your own zone. Of course, regular mailers and WhatsApp messages will be sent to everybody as is usual. Then yes, and next week, of course, on the Tuesday, we will have Dr. Radhika with us. I will add the details as soon as possible. And this is a time I always say thank you. There have been a lot of you. There has been, so I have to take that moment to thank you, because actually without all of you participating and being here, this just would not happen. Some 266 people have watched today or have been with us. Out of that, some 65 of you, I think, have commented. And I'm going to just read out all those who are there, at least who I know are there. So Dr. Rastogi, Dr. Nandini, Dr. Osmani, who's there all the way from Ecuador, Dr. Karpaga Selvi, Arpan Shah, Deepamala, Leena Sankari, Revati. Please excuse me not saying doctor for everybody, that's a taken. Joss Hille and Pushpanjali Das, Priya Kartik, Ravi Prakash, Pushpalata, Niraj Sethi, Olafun Lola, Dr. Barpande, Malskam, Priyanka, Courtney, Aparna, Rajkumar, Mutoni, Rahul Patil, Divya, Jyotsna, Shruti. I think that was Dr. Nasser who signed in. Okay. And Dr. Jaya Joshi, Priyanka, Dr. Rahul Patil, Veena Nayak, and Dr. Pushpalata, Neva, and Rati. I hope I got everybody's names. Thank you again so much for being with us, for taking the time to type in your comments, and all those who attended and who did not type also, thank you so much. Another thing is, if you are interested in the certificate, please just check in the description, and also before I actually log out, I will put it in the live chat, and you can just go ahead and go through the process and finish that. Once again, it has been wonderful having you here. Please, if you enjoyed the session today, put a like. So Dr. Pouyan knows you liked it. And also share, comment, interact. In the meanwhile, till Friday, have a fantastic time. See you this Friday. So this is taking me a minute longer to actually get that link and put it here. Sorry for that. It's also in the description. So I think I will just let that be. You can find it in the description. Have a nice week. See you all later.